So this is a face transplant. This is probably the most recent publicized one. This was a young lady from the Cleveland area. She is about 20. Was having a lot of, a lot of stress, very, very severe trauma in her life. And she unfortunately decided to take her life, but she did survive. And this is her pre, and this is her post-op, and then this is her donor, which this was in National Geographic about maybe 2 or 3 years ago. As you're probably aware, when they do a face transplant, these are very, very personalized, and they generally do not publicize these until way after. It's a really long recovery period. And as you can imagine, you have to get permission from, or, permission from the donor family to share, because, that's a very, very personal topic, and it's a lot of the donors are very excellent in that they're okay with sharing and things like that, but we do have to respect, what their wishes are. So this was done at Cleveland Clinic. Currently in the United States, there are a number of face transplant programs. The most active is the one at NYU, Indications for Transplant. So basically, the hand transplants mostly fall in the category of burns, trauma, which would be car accidents. A lot of times they have severe burns and injuries, birth defects, wounded warriors, war injuries, things like that. With the birth defects, sometimes those are challenging because they don't have enough neurological firing of the nerves, that they would have to be a low level, like around the wrist. That would work. Then the facial transplant would be, most categories fall into burns, trauma, some birth defects, and animal attacks, which we've seen a lot of that in the news. I think there was a very well publicized lady that was attacked by a domesticated animal, and her face was sheared off. The penile transplant is a newer one, and the most common reasons for that are cancer. They would have to be 5 years cancer-free. Micropenis, which is where the children are born with basically, not really much of a penis. Birth defects and trauma. And the one that we did do here at Hopkins was due to an IED explosion in Afghanistan. The uterus is our newest one. We're opening that in the next year. And this one, the indications for that would be cancer, prior hysterectomy, or there is a disorder called MRKH syndrome. And these patients are born without a uterus. So we will be opening that again later this year or early next year. There's only a few in the country that are doing that, and they're having very good results. This is a lovely photo of a young man who lost his hands and had a transplant, and is doing really well. He was done, let's see, at the Children's Hospital in Philadelphia. He's been on TV a lot, and he's kind of really, really been a champion at raising awareness for the need for BCA transplants. So the evaluation of these patients, this is how we do it here. Most programs do it in a similar way. We do a phone screen. I talk to the patient for about an hour. I review their medical information, collect their records, and then I send it over to the surgeons. And then if they feel that would be a good candidate that might, we could help in that way, we schedule a visit. They come in for a couple of hours. And then if the patient and the surgeon feel that this would work out, we do an evaluation here at Hopkins, it takes about 4 days. It's really extensive. It includes psychology, social work. We do a lot of radiology studies. They see cardiology. They make sure they have good lung function, because these surgeries are really, really long. A double bilateral hand transplant's about 12 hours. A face can be up to 24 hours. The uterus is probably going to be about 8 hours, and the penile transplant was greater than 12 hours. So we have to make sure they have really good lung function as well. We do have our own anesthesia team that deals specifically with the tissue transplant patients. We have 2 anesthesiologists that they're on call, and when we do start the surgery, they get called, and they have a pretty large team. There's about 4 or 5 of them with the patient at any given time. So the uterus evaluation, it's a little bit different than the others. It's so basically we start with a phone screen. Then they would visit with us for about 2 or 3 hours. We would review everything and talk about what questions they would have, and kind of go back and forth. It's somewhat informal. And then if we feel that this would be a patient that would, the patient and we agree that they would be interested in evaluation, they would come in for 4 days. If they are a candidate, then they would go forward, and we would have to do an in vitro fertilization procedure. And they would have to have a certain number of good quality embryos before we can proceed to transplant. So that's just so that the patient has the embryos banked, and then when we do the transplant, about 3 to 6 months later, they would have an embryo transfer. At this point, we will only be using living donors. Some programs use deceased donors, but for our purposes, we thought that the living donor would be a good fit for our program. So again, that will be opening further down the road, but that's kind of the pathway that we'll be using. And it's pretty consistent with what the other programs in the U.S. are doing. After all of this information and after they've been evaluated and had all their studies done, I give the patient, of course, results immediately. So they're well aware of, usually these are all younger patients, so we don't really find anything medically wrong with them. We kind of know going in that what their health history is. So then in following the evaluation, the 4-day evaluation, we would have a selection meeting to review the candidates, and this way everyone could review all the data, and it would include surgery, nutrition, pharmacy, psychology, social work. Infectious disease weighs heavily on these because some of these patients have had, particularly the ones in the military, they've had a lot of exposures to infectious diseases, and they've also been in the hospital a long time before they ever come here. So we have to review their infectious disease profile. The ones getting the uterus transplant, we will do that, but they probably won't have as extensive of an evaluation on the infectious side because they're pretty straightforward. Young women just without a uterus that, they don't have like a lot of hospitalizations and things like that. So then if they're selected, they'll be listed. They have to be within 8 hours travel time of Hopkins so that we can, when we get the call, they can come in. Waiting times for a donor are variable for the hand, face, and penis. We do list them, but they have to have a skin match, a size match. There's just a lot that goes into it. These are not organs that we are allowed to procure unless we get consent from the family or significant other. So these donations are basically, yeah, they're not like on your driver's license. The OPO are very experienced at dealing with this, and they will tell the family a little bit of background about the patient, such as wounded warrior, lost hand in farming accident, something like that, so that, the family or significant other can make a decision on, whether they want to donate. So then the matching criteria for ours are a lot different. These are life enhancing transplants. They're not life saving. So we have a little more leeway. Plus the patients generally are younger. So we have to look at long-term, like things that would cause problems. So they have to be an exact ABO blood match. For the hand, face, and penile transplants, we do a bone marrow infusion on day 14 to induce the immune response so that we can use less immunosuppression on. Then again, this is designed, this program was designed under the direction of Dr. Brandiker. And so this has been what the program's been doing since it started, I believe. The program actually started in Pittsburgh, University of Pittsburgh. So then we need a CMV and EBV status that match. As you know, the mismatch can cause problems with viremia, so we have an exact match on those, the size, the skin tone. No identifiable tattoos on the patient, because that would be a way for people to identify who the donor was. The next thing is complications. These are kind of the ones you would expect: bleeding, vessel thrombosis, tissue necrosis, sepsis, medication reactions, transfusion reaction from the stem cell infusion, and direct trauma to the graft. The hand transplants, you have to be really careful because they don't have any sensation. The nerves regenerate very slowly, so they're put in like splints by hand therapy post-op, and they basically go home with that, and they would get hand therapy every day, at least Monday through Friday for at least a year. So and the nerves grow in really slowly, so they really don't have sensation. You have to be careful with that. The uterus, of course, we don't have to worry about having trauma to the graft. This is a picture of the team that was there for the penile transplant. It was just some of the people that were there. It was it was a lot of people that were there during that procedure. Our immunosuppression protocol, the hand, face, and penile transplants are given CAMPath induction. They're on reverse isolation to prevent infection. We start the oral Prograf for tacrolimus on post-op day 1. For the tissue transplants, most patients have an episode of rejection between 3 and 6 weeks post-op. And our rejection is often just treated with topical steroids. A lot of times that just turns it right around. Occasionally we have to use IV steroids, but the good thing about the tissue transplants, minus the uterus, which is going to be a little bit different for us, is we can just see the rejection. We do biopsy every episode of rejection, generally, unless the attending feels otherwise, but we treat it with IV steroids for a more extensive rejection or resistant. The bone marrow infusion would be around day 14. It's crushed up bone marrow, and that the 2 times I've been present for that, it goes pretty well. The patient did not have any side effects, and it's pretty, it's not uncomfortable for the patient. The uterus would not be getting that because they would be on a different immunosuppression protocol. The single dose immunosuppression, this would be for the hand, face, and penile. We have the initial T cell depletion with CanPath. Then we have the donor bone marrow cells for a second stimulus for immunosuppression. And that would elicit a host alloimmune response that triggers exhaustion and depletion of the host lymphocyte clone. These the composite tissue allografts are the only types of grafts to include the donor bone marrow component. And it represents a constant source of donor-derived stem cells, but it also favors chimerism, induction, and maintenance. The single agent immunosuppression, the benefits include reduced risks of hypertension, diabetes, hypercholesteremia, tremors, osteoporosis, GI side effects, and leukopenia. It can possibly also reduce the risk of skin cancer and other malignancies because you're on a lower dose. The uterus transplant, we would be using the traditional tacrolimus steroid, and it would also be using Imuran because mycophenolate is teratogenic. So we couldn't use that for the uterus transplant. This is a photo of a baby born after a uterus transplant, and then post-op care of the hand, face, and penis transplants would be, we keep the room really warm. This is to basically help with perfusion of the transplanted graft. We have to keep them adequately hydrated to prevent blood clots, microemboli, vessel thrombosis. They're generally on a specialty bed so that prevents bed sores. We have them on contact isolation with masks to prevent infection. We do flap checks, which is the temperature, the capillary refill, and we also have an arterial and venous signal that we check with a Doppler. All of these patients are followed by physical therapy, occupational therapy, and speech therapy. Particularly the face transplant would need more speech therapy than the others because of the area that's being transplanted and the impairment of the nerves and muscles of that area. It's very important for the staff to maintain patient confidentiality. We ask the staff not to discuss this with family or friends. And we also do not mention where the graft was procured, as it might reveal the donor identity. We use no germline tissue, which is testes, sperm, and gametes, to be transplanted as part of this protocol. This is one of our bilateral hand transplants. He was injured in Afghanistan, and he's a very excellent advocate for wounded warriors and the transplant community. He does a lot of public speaking about PTSD and trauma. So we're pretty close to all of our patients. We talk to them really, really frequently. They see us at least once a year, if not more often. So it's nice. We know their families, and it's kind of it's a very personalized service. So that's pretty much it in a nutshell. What questions do you have?
We did have in the chat, we did have Jerry Chiat mention that, or Eileen, I'm sorry, Chiat mentioned that the day that she was donating a kidney at University of Maryland, Dr. Barth was supposed to do that surgery, but he got called to Hopkins to help with one of the first face transplant in 2012. I don't know if you were involved with that then or there then, but that was a comment from Eileen and Jerry Chiat.
Oh, no, I wasn't here. I came here in about 2016. Yeah, somewhere around there.
Mm-hmm.
But that's so exciting. Yeah, it's just so many areas for growth in this transplant population.
Do you find that these VCA transplants, that the transplant centers across the country, there's more and more of them now delving into this new area of transplant?
Yes and no. There's a very low volume in this area, as you know. So I don't see too much expansion on the hand, face, or kidney realm. There are several other uterus transplant centers, but it's really hard to open up a center. It takes a lot of staff and resources. So it's a lot of hurdles to open. So, but I do think the uterus is going to be the next frontier because there's a large population that needs this, and it's only a limited time. They would keep the uterus for around 5 years, 1 to 2 pregnancies. So they wouldn't have all these side effects that the other patients that we would have to worry about, or, that we would have to concern. So, and it's a young population and healthy. So I think there's a lot of need for that. Fortunately, we don't get a lot of calls for hand, face, or penile transplants. And as you probably know, they can be sometimes managed by reconstructive surgery. So that's a really good thing when, we have someone that we can help in that realm. And each call that I get, I do triage to reconstructive surgery if that's needed. Because, yeah, so our pool of patients that actually need us, it's kind of small. But it's like I said, this uterus is so exciting because people are able to have a baby, and it's I think what we're learning from it too, the research that goes with it will help us with all the other programs.
Do these transplant patients, do they need, especially the face transplant, do they need a lot of therapy? Do they need a lot of help dealing with the changes, now in their life and their look?
Yes. Now, we haven't done one here, but I have spoken with other centers, and they do need particularly a lot of speech therapy because of the effect of the tongue and the muscles and everything, and swallowing. That can be a problem. A lot of times they do end up with a feeding tube for a brief time until all the muscles return function. Sometimes during the accident, the initial trauma, they've lost their teeth. So there's just a lot of things. But yeah, moving the muscles of the face. And they're often very weak after such a huge surgery, 18 to 24 hours. They need a lot of physical therapy too. So all of that is ongoing for quite a while, particularly the face and the surgery from the occupational therapy, as well as the hands. They are in therapy for their occupational hand therapy for 1 to 2 years. It's a really long road, and we do tell them that, and that's why some of them come in and then they decide, that's not for them, or it is. Usually, if they need a bilateral hand, though, I think it's more pressing that they feel like they do need to get a transplant. A lot of the single amputation, single arm, they do pretty well with a prosthetic. So it's not easy. That's why we're very close with them. We talk to them really often. It's kind of nice. We keep the door open, so to speak, because yeah, they go through a lot, and emotionally it's exhausting for them and their family. So we're usually able to, kind of intercept and help out with things and kind of make it as smooth as possible. And the attendings that do the surgeries are unbelievable. It takes a lot of research too to get these things off the ground. That's why, it's not easy to open a program.
That's amazing. It's just, I mean, solid organ transplants are obviously miraculous in my mind, but then hearing of some of these and maybe changing someone's life that has no hands, it's just kind of unbelievable. It's almost like out of science fiction, I think. Can you share an experience you had that maybe was the most awe-inspiring, what you were involved with a hand, or even working on the uterine piece? Is there something that just, just was just, yeah, so stands out, was so kind of miraculous to you that you're so glad that you're in this field that made it all worthwhile for you?
Yeah, I think it's coming and seeing the patients come in for their visits. A lot of times they just look like they're just feeling so much better and they're regaining their independence. So that is such a feeling. And I like problem solving. I like when they call with a problem and we try to get them answers. A lot of them, it's pretty easy to solve, and we do try to make their life as smooth as possible because with these huge traumas, they've just encountered so many obstacles. So, and the attendings are fantastic. Whatever they need, they go way out to make sure that they have every last thing that they need. So it's kind of a fun service. It's very small, but yeah, but it's busy because we handle a lot of different things and we do get a lot of referrals. So I like the challenge of it. And then like seeing the patients, it always feels so good, and their families. That's always fun. So
That's amazing. And Scott just put up a question. Scott, we're glad you're over COVID and you're doing better. He asked, with a face transplant, what exactly is transplanted? Skin, cartilage, muscles, etc. What are the components?
we don't have a program that, well, we haven't done one here yet, but it really depends on what they need. Some patients just need like a mid face, like a nose and mouth. Some need the entire. So there would be muscles and cartilage and everything that would be transplanted. But yeah, we have not had. That's one that there has been less number of transplants than the hands. And of course, the penile, there's only been two in the country. So these are, like I said, it's a very, very small, small service. But yeah, the faces, I don't know how many they're up to right now. I'm not sure, but I know that that's not a huge number in the United States. I know in France, there is someone that does a good number, but a good number on faces could be 10, because they're so time consuming, and the follow-up is really involved, like ours with the hands. We see them every week, every other week, immediately post-op. We keep a really good eye on them. And a lot of times we get pictures too. We have them send photos of how their graft's doing, and so we keep in really good contact with them and their families or significant other, whoever their support team is.
Amazing. A question, do you have videos of how these patients functions with their limbs and face after the transplant? Do you?
We do, but we keep them private unless it's something that's filmed for like a documentary. So all of the things that we have, we keep them pretty much. They're pretty much with the attending in a private file. But yes, we do videotape the hands transplant patients when they come in for their yearly visit, and again, that's a confidential file. But some of them do outreach, so and that's, we encourage them to do what works for them. If they want to be anonymous, that's great. If they want to, some of the wounded warriors do a lot of outreach, or they may do it anonymously, because they've always expressed that they want to help others going through a similar situation. So they've been very, very generous with that. All of our patients have, really. So I can't say just one group or another, but yeah, so it's nice. I mean, it's a nice group of patients, and yeah, they've just been through so much. I can't even imagine um, what they
Wow.
what they've been through. So we try to keep it very straightforward, very, troubleshoot problems, try to keep the treatment plan as smooth and pulled together as possible, because I mean it's like a full-time job recovering from these transplants. So the uterus, I anticipate it'll be similar, and that the first couple months after transplant, we're going to have to really see them frequently, do a lot of labs, then they're going to have their embryo transfer. So yeah, so it's kind of fun. I
And
enjoy them all.
the uterine transplant, when do you expect? Has that already started, or when do you have that on the books as beginning at Hopkins?
We have a few more things to finish up, but yeah, we're hoping within a year. Yeah, it's just a lot. It's a lot that you have to go through to open a program, and that's why I'm surprised they even have as many as they do, because it's another full-time job to open a program. So,
Oh,
and we have a huge amount of staff here working behind the scenes. So yeah, you would probably need a large facility with a lot of support. And we do have great support uh, from the administration at the hospital. They really go out of their way, and our medical director, Dr. Brennan, and lots of people that I've left out, but not intentionally. But yeah, we have it's a very well organized system here. So, but yeah, it's a lot that goes into it in a
Gwen,
good way.
yeah, absolutely. Gwen has asked, have the insurance companies warmed up to this? Do they see it still as experimental? Are they justifying the cost? Are they kind of with you guys on this and not giving the patient any issues?
Well, that's something that's in evolution. We fortunately, very lucky, we have Joe Line, who's our transplant finance expert. And he's really go on a case by case basis. So yeah, they do the transplant and then of course see what insurance will cover. Um, the hospital has agreed to assist with 5 uterus transplant surgeries, parts, not the IVF, but some other things. So we do get some great support from the hospital. And then, but yeah, insurance is an issue that we're working on. And that's been ongoing since I started here about 6 or 7 years ago, and we'll get there. It's just going to be a steady progress, yes. And we do feel terrible, that it's not covered yet. But I mean, I think all the organ transplant programs started out the same way.
Yeah.
And yeah, so we're very proactive for our patients. And Joe Line is phenomenal. She's been doing transplant finance, I think, for maybe 30 years. So she kind of knows all the ropes and how to, how to put things through to the insurance companies. That's kind of half of it. And then I do a lot of prior auths and talking to the insurance company. I mean, we all do. And we have our research director. We all and we do have meetings about that every month, about covering the needs of the VCA transplant patients. So it's quite a few people working on that. Very dedicated.
Scott has asked, I just lost him. Scott has asked, are there restrictions on the type of death of the donor as there are with some solid organs? For example, can hands be procured after cardiac death or just brain death? Are there any limitations on how the donor has passed away?
Yeah, we can't do a donor after cardiac death. They have to be like a brain death. The perfusion time is really a tight window. And we can only go about a 500-mile radius because of that, the ischemic times. So yeah, so that unfortunately that may change as things get better. But right now we're very conservative and we err on the side of caution. So yeah, but yeah, things are moving all the time though.
That's good. Danette asked, how many penile transplants have there been? And she said that she was informed that one of her family members was used in a penile transplant.
There's only been 2 in the United States. The first one was at Mass General, and that was for an amazing man who had penile cancer, which we are authorized to do transplants for that. They have to be 5 years out of in remission or cured of their cancer. And it was very exciting that he came out and did a lot of public speaking to raise awareness of that. And then the second one was done here at Hopkins. The patient was a wounded warrior, and that's the only 2 in the country. There have been reports of other ones in other countries, but our 2 pretty much are the ones that I'm aware of. Yeah, fortunately, very fortunately, not too many people need this. We are open though, if anyone knows a patient, they're most welcome to call. But a lot of these can be handled via reconstructive surgery, fortunately. But if there's more than 75% of the penile loss, then they would fit in the realm of transplant or specific injuries.
Wow. Just amazing. Are there any other questions for Jane? We do appreciate your time. Sorry, you hit all those road closures. I wonder what was going on.
Well, I live downtown, and I think it's a big fall season. We're having a lot of festivals.
Oh, the Fells Point.
And
Yeah.
And I drove around the corner, and I'm like, whoops, the road's closed. I am so sorry.
You're right. The Fells Point Fall Festival is this weekend, and
It's so pretty. Yeah, we're lucky we live in a great town. Lots of good things to do.
absolutely, absolutely.
Well,
So, any other questions? Last call. Again, thank you so much for coming in and telling us
Hustling it.
about all these exciting things. And I'm so happy for these people. That's just fabulous. And I'm glad that Hopkins and University of Maryland, we're so lucky to have great transplant centers right here in our
Yes.
backyard that handle so many of these things.
Yeah, and they do have a combined plastic surgery program at the University of Maryland. So everyone, yeah, it's a nice, it's nice that we both blend everything together.
Oh, that's
So,
awesome.
yeah, our residents train over there at Shock Trauma, and yeah, we have a very good relationship with them, and yeah, our team here is just so patient centered. So it's really a joy, and it's a joy to see the patient grow after the transplant, just start feeling better. So it's really a pleasure. Well, it was very nice seeing everyone. If you do have questions, just email me or send via Michelle. Happy to answer. I know this has been kind of just a brief overview, but it gives you a picture of like what we do and kind of what the patients go through. Yeah, it's a really exhausting, very grueling post-transplant. But we're learning all the time. We have research ongoing, and we're trying to make things better. One step at a time.
Okay, well,
That's great.
Well, we thank you. Thank you very much for attending today's meeting. Once again, Michelle and I love seeing everyone. A reminder to check out our events page on our website for advance notices for our future meetings. Don't forget to check out our website at www.triomaryland.org. All our past meetings are on our YouTube channel, and there for your convenience. The speaker notes from today are already on our website. We want to thank everyone so much and have a great September, and we'll see you in October.